Okay, picture this scene. The emergency room doors absolutely burst open. A patient is wheeled in, deeply comatose, and their heart rate is just dangerously erratic on the monitor. Now, here's the kicker. Just an hour ago, they were perfectly fine. You are suddenly fighting a high-stakes, ticking clock medical emergency. And the culprit? It's not some rare, exotic toxin. No, it's a standard medication sitting in millions of medicine cabinets around the world right now. Welcome to The Explainer. Today, we are creating a complete animated explainer of a comprehensive medical summary of cyclic antidepressants. Our goal? To make sure everything present in this summary is explained in this animated format without losing a single vital detail so you can master this toxidrome. It's a pretty terrifying question, isn't it? What actually happens when a standard daily medication suddenly flips into a rapidly lethal poison? Well, with cyclic antidepressants, the line between therapeutic relief and absolute cardiovascular collapse is remarkably thin. The clock starts ticking the very second of overdose, and your window to intervene is incredibly narrow. So let's run through our clinical checklist real quick. We're going to cover 1. Meet the cyclic antidepressants. 2. The ticking clock of their presentation. 3. Diagnostic ECGs. 4. Resuscitation and management. And finally, number 5, final disposition. Okay, Section 1, meet the cyclic antidepressants. Before our patient even gets to the resuscitation bay, we need to know exactly what kind of chemical weapon we're dealing with here. Cyclic antidepressants are mostly categorized by their molecular structure. First up, we have the tertiary amines. This includes amitriptyline, imipramine, doxepin, clomipramine, and trimipramine. These guys are strong inhibitors of serotonin reuptake, and they're notoriously tricky because they actually convert into active secondary amine metabolites once inside the body. Then we have the secondary amines, like nortriptyline, desipramine, and protriptyline. Now, these strongly inhibit norepinephrine reuptake, are generally linked to somewhat lower cardiovascular toxicity than their tertiary cousins. Oh, and I definitely want to draw your attention to the structurally related tetracyclics. Amoxicillin carries extrapyramidal symptoms and a uniquely high risk for seizures, and the same goes for maptyline. To treat the poison, you really have to know how it moves. These drugs have rapid GI absorption, though. In an overdose scenario, their own anticholinergic effects can drastically slow down gastric emptying, which delays that absorption. They're also highly lipophilic. That gives them a massive volume of distribution. We're talking greater than 10 to 50 liters per kilogram. But here is the absolute most important pharmacokinetic fact you're going to learn today. They're extensively bound to plasma proteins, and this binding is highly pH dependent. Alkalemia significantly increases this protein binding. Lock that fact in your memory for sure, because that little physiological quirk will literally become our cure later on. Lastly, just note that less than 5% is excreted unchanged by the kidneys, so relying on renal clearance isn't going to save us. Now, what's really fascinating here is the direct cause and effect of this multi-receptor assault. First, the drug blocks the fast inward cardiac sodium channels in phase 0 of the action potential. This slows depolarization right down and causes severe conduction delays and ventricular dysrhythmias. Second, it competitively blocks peripheral alpha-1 receptors, and that causes a refractory vasodilatory shock. Third, it assaults the central nervous system through muscarinic anticholinergic blockade, which causes delirium and coma, and by antagonizing the GABA-A receptors, totally lowering the seizure threshold. Finally, histaminergic blockade causes deep sedation, while initial monoaminergic reuptake inhibition can actually trigger early transient tachycardia or even serotonin syndrome. Section 2. The ticking clock. The chemical payload has been delivered. Now we shift our focus to those emergency room doors as the patient rolls in. The timeline for cyclic antidepressant toxicity is just brutally fast. The onset of severe, life-threatening manifestations typically hits within just 1 to 2 hours of ingestion. If an overdose is going to show its face, it's almost always going to fully manifest within 6 hours. This is exactly why that initial period in the ER is so intensely critical. You literally do not have time to wait and see. When they do crash, here is what it looks like. Cardiovascularly, sinus tachycardia is actually the most common dysrhythmia you'll see, driven by those anticholinergic effects and reflex sympathetic drive. You're going to see conduction disturbances, ominous hypotension, and ventricular dysrhythmias, sometimes even mimicking a Brugada pattern with that coved ST elevation in V1 through V3. Neurologically, they'll show altered mental status ranging anywhere from lethargy to a deep coma. You'll also spot the classic anticholinergic toxidrome, dilated pupils, hyperthermia, dry flushed skin, and urinary retention. Keep a really close watch because brief, generalized tonic-clonic seizures are incredibly common here, and they very often act as the immediate precursor to total cardiovascular collapse.
Section 3, ECGs and diagnostic testing. We know what it looks like on the outside. Now we have to look at the heart's electrical system. For this toxidrome, the standard 12-lead ECG is the absolute star of the show.
You are looking primarily at the QRS duration. When the QRS widens to greater than 100 milliseconds, the danger scales up instantly. This specific metric predicts an increased risk for seizures of up to 34%. It is your very first major warning sign on the monitor.
And this just brilliantly illustrates the escalating danger. If that QRS widens past 160 milliseconds, the patient's risk for deadly ventricular dysrhythmias, like VT or VF, spikes all the way up to 50%. The wider the complex, the closer the patient is to falling right off the cliff.
Beyond just the width, you want to look for a rightward axis shift of the terminal 40 milliseconds. This shows up as a prominent R wave in lead AVR greater than 3 millimeters, which is a classic hallmark of severe sodium channel blockade. You'll also likely see QTC prolongation thanks to potassium channel blockade. For lab testing, an arterial or venous blood gas is absolutely crucial to assess systemic pH, and a serum acetaminophen level is a mandatory screen for any multi-substance ingestion. But let me be perfectly clear about one thing. Quantitative serum TCA levels are practically useless for acute toxicity. They just do not correlate with clinical outcomes. Never ever delay resuscitation waiting for a TCA level to come back from the lab.
Section 4, Resuscitation and Patient Management. The alarm is sounding. The QRS is widening. We're now entering the active phase, and our pace has to perfectly match the high-stakes urgency of this situation.
If you catch the ingestion within 1 hour, single-dose activated charcoal at 1 gram per kilogram, up to 50 grams max, can be given to decontaminate the GI tract. But please hear this warning loud and clear. You only do this if the patient's airway is definitively protected. Delaying early endotracheal intubation in an obtunded patient just so you could administer charcoal creates a massive, lethal risk of pulmonary aspiration. Also, just a quick note, routine orogastric lavage and whole bowel irrigation are simply not recommended anymore. Protect the airway first, always. So the absolutely crucial point here is how we actually defeat that sodium channel blockade. The antidote is sodium bicarbonate. Remember how we said protein binding is pH dependent? By giving 1 to 2 milliequivalents per kilogram of bicarb as an IV push, we achieve two major things. First, the massive flood of extracellular sodium overcomes the competitive blockade. Second, the hypertonic alkalization physically decreases the unbound free drug, literally blasting it off the cardiac receptors. You just repeat these boluses every 3 to 5 minutes until the QRS narrows below 100 milliseconds or their blood pressure improves. Then you start a continuous infusion, adding 150 milliequivalents to a liter of D5W, targeting a strictly maintained serum pH of 7.45 to 7.55.
What if other systems are failing? For refractory hypotension despite fluids and bicarb, we reach for direct alpha-1 agonists like norepinephrine or phenylephrine to overcome that blockade. For desperate, crashing hemodynamic collapse, intravenous lipid emulsion is your rescue therapy. If you've got refractory ventricular tachycardia or fibrillation, sodium bicarb is still first, but lidocaine is your second-line agent. For those violent seizures, hit them with IV benzodiazepines or propofol. And hey, don't even think about calling for dialysis. The toxin's massive volume of distribution and high protein binding make hemodialysis completely ineffective.
Actually, let me drop my tone here for a second because these next points are critical, life or death medical errors you absolutely must avoid. Under no circumstances should you give class 1A or 1C antiarrhythmics like procainamide or flecainamide. They will tragically exacerbate the sodium channel blockade. Class 3 agents like amiodarone, they'll worsen the QTC prolongation. Beta blockers and calcium channel blockers will absolutely tank their already failing blood pressure. If the patient is seizing, do not give phenytoin. Phenytoin blocks cardiac fast sodium channels and will just worsen the cardiotoxicity without even stopping the seizures. And finally, avoid dopamine for blood pressure as the patient's endogenous catecholamine stores are already entirely depleted by this point.
Section 5, Final Patient Disposition. Okay, the resuscitation is successful. The heart rate stabilizes. We can finally take a breath and slow down our pacing as we move into the safer monitoring phase.
So how do we know when they are truly out of the woods? If a patient remains completely asymptomatic, has normal valve sounds, and most importantly, has a perfectly normal 12-lead ECG for at least 6 hours post-ingestion, they can be medically cleared. Naturally, they are going to require a psychiatric evaluation if this was an intentional ingestion.
However, if the patient showed any signs of toxicity at all, like altered mental status, ECG changes, or hypotension, they require strict ICU admission. They cannot be cleared until they have been completely asymptomatic with a normalized ECG for a minimum of 24 hours. As we wrap up this explainer, I want you to think about this final question. How narrow is the line between therapeutic pharmacology and a lethal toxicological emergency? With cyclic antidepressants, that line is razor thin, dictated by microscopic shifts in blood pH and literally milliseconds on an ECG tracing. It's just a profound reminder of the immense power hidden inside everyday medications and the incredible, rapid-fire clinical precision required to bring a patient back from the brink.